The shoulder girdle is frequently a source of pain and disability. Research has suggested that shoulder pain is as common as 16 to 21% of the population. The shoulder girdle is designed for mobility, which comes at the cost of instability, especially in the glenohumeral joint. The shoulder girdle is a complex function group comprising of 4 joints, 3 synovial and 1 muscular, 3 bones and at least 17 muscles. The 3 bones involved are the scapula, humerus and clavicle. The synovial joints are the glenohumeral, acromioclavicular and sternoclavicular. A muscular joint is between the thoracic cage and the scapula, creating the scapulothoracic joint. Observation. The patient should be standing for this examination. Begin with a general inspection of the shoulder joint from the front, side and back. Look for symmetry, wasting, scars or any obvious bony deformities. Active range of movement. Ask the patient to raise their arm until it points up to the ceiling for flexion, which averagely should be between 150 and 170 degrees. Next, ask the patient to keep their arm straight and extend it behind them for extension, averagely 40 degrees. For abduction, ask the patient to lift their arm away from their sides as far as possible, between 160 to 180 degrees. Simultaneously, palpate the inferior pole of the scapula to assess degree of movement at the glenohumeral joint versus the scapula, which should normally be 50 to 70% at the glenohumeral joint. For adduction, ask the patient to bring their arm across the trunk to the opposite side, and then, for internal and external rotation, ask the patient to hold their arm in 90 degrees of abduction and ask them to flex their elbows to 90 degrees and with their hands facing down, push their hands backwards for internal rotation, which should be around 90 degrees, and in this position, ask the patient to move their hands to face upwards, pushing their hands backwards for external rotation, which should be around 80 degrees. For combined internal rotation and adduction, have the patient's elbow flexed at 90 degrees, arm by their side. Ask them to place their hand behind their back and reach as far up the spine as they can manage. Average is around T5 for internal rotation. Ask the patient to do a mini press-up on the wall to note any excessive scapular winging, which could suggest weak serratus anterior or damage to the long thoracic nerve. You can also assess scapular movement. Ask the patient to roll their shoulders forward for protraction or abduction. Squeeze their shoulder blades back together to assess retraction or adduction of the scapulae. Assess elevation by asking them to shrug their shoulders and then depress their shoulders by pushing their shoulders down. Also, assess the shoulder blades during shoulder abduction for external rotation, and then they return their arms to their side for internal rotation. The close-packed position of the glenohumeral joint is maximal abduction and external rotation. For the acromioclavicular joint, the close-packed position is 90 degrees of abduction and the sternoclavicular joint is full elevation. Capsular pattern of restriction. Dr. James Cyriax was the first to extensively study soft tissue lesions. When inflammation of a joint is present, known as synovitis or capsulitis, not only does passive stretching of the capsule cause pain, but a limitation of range of movement of the involved joint is always found to be in a specific pattern. This pattern is always similar for that particular joint. McGee stated that the glenohumeral joint pattern of capsular restriction is that lateral rotation has the most loss of range of motion. Second to that is loss of abduction, and finally the least loss being medial rotation. Palpation. Feel over the joint and its surrounding areas for the temperature of the joint. A raised temperature may suggest inflammation or infection in the joint. Systematically feel along both sides of the bony shoulder girdle. Feel for the sternal end of the clavicle, the acromial end of the clavicle, the medial border of the scapula, the spine of the scapula, the lateral border of the scapula, the acromion process, the subacromial space, the coracoid process, the greater tubercle of the humerus, the intertubercular groove of the humerus, the lesser tubercle of the humerus. Passive range of movement. Feel for any changes in the range of movement and the end range of the movement. Feel also for any crepitus whilst moving the joint. The end ranges of movement should feel as follows: flexion, elastic or firm capsular; extension, firm; abduction, elastic; Adduction should feel like soft tissue approximation, blocking the end range. Internal rotation should feel elastic, and external rotation should feel firm. Abnormal end feels could be empty, which would suggest severe instability, hard capsular, which could suggest a frozen shoulder, or a myospasm, which could also suggest instability. Assess the scapular movement with the patient's side lie: retraction, protraction, elevation, depression.
External and internal rotation.
Accessory movements. Accessory or joint play movements are joint movements which cannot be performed by the individual. These movements include roll, spin, and slide, which accompany physiological movements of a joint. The accessory movements are examined passively to assess range and symptom response in the open pat position of a joint. GH accessory movements. Traction. Arm at about 50 to 70 degrees abduction and pull the arm on a long axis, holding about the elbow. Repeat this at other positions, for example 90 degrees, etc. Distraction. Have the hand on the inside of the patient's arm and push out whilst holding the elbow and pushing medially. Anterior glide, which is also used as a special test for laxity of the joint. Hold on to the humerus head and onto the anterior clavicle and pull anteriorly on the humerus head. If excessive movement, this is a positive anterior draw test. Posterior glide, which is also used as a special test for laxity of the joint. Opposite with hand and posterior spine of scapula. If excessive movement, this is a positive posterior draw test. Inferior glide. Pull down on the humerus head, similar to traction, but with the arm by the side of the patient. Acromioclavicular joint accessory motions. Posterior anterior glide. Pinching the clavicle carefully, push and pull with a minimal movement. Inferior superior glide. Again, pinching carefully on the clavicle, push and pull with a minimal movement. Sternoclavicular joint accessory motions. Posterior and inferior glide. Pinch the clavicle carefully and push and pull with a minimal movement. And inferior and superior glide, repeat this inferiorly and superiorly. Special tests. Anterior slide test. This tests labral pathology. Have the patient upright with their hands on their hips, thumbs facing posteriorly. Stand behind the patient and stabilise the scapula and the clavicle with one hand. With the other, apply an antero-superior force to the elbow while instructing the patient to gently push back against the force. A positive for this is pain or reproduction of symptoms or a click. Apprehension test. This tests glenohumeral joint stability. Have the patient standing or supine. Abduct the shoulder to 90 degrees and move it into maximum external rotation. If movement is well tolerated, apply a posterior-anterior force to the humeral head. A positive sign would be apprehension and pain. Biceps load test 1 and 2. This tests superior labral pathology. Have the patient supine with the shoulder in 90 degrees abduction, the elbow in 90 degrees flexion, and the forearm supinated. Externally rotate the shoulder until the patient becomes apprehensive. Maintain this position. This part is biceps load test 1. Biceps load test 2. Ask the patient to resist that elbow flexion. This test is positive when a pain and apprehension remains unchanged or increases during resisted elbow flexion. Clunk test. Tests a tear of the glenoid labrum. Have the patient supine, abduct the shoulder over the head and apply an anterior force with the hand under the shoulder and rotating the humerus laterally with the other hand. Feel for a grind or a clunk which may indicate a tear of the labrum. Crank test. Performed with the patient lying and elevating the shoulder with the elbow flexed at 90 degrees. An axial load is applied while the arm is rotated internally and externally and circumducted. A click associated with pain makes the test positive. Apley scratch test. Apley upper. This tests restriction in external rotation, abduction and flexion. Ask the patient to abduct their arm with a palm on their back, trying to reach the lowest vertebra. Positive when there is a restriction compared to the opposite side. Aptly lower. This tests restriction in internal rotation, adduction and extension. Have the patient put the dorsum of their hand on their back, trying to reach the thumb to the highest vertebra. Positive when there is restriction compared to the opposite side. Aptly scarf test. The scarf test is performed with the elbow flexed to 90 degrees, placing the patient's hand on their opposite shoulder and pushing back. Look for any discomfort. Codman's or drop test. The shoulder is abducted to 90 degrees and the patient asked to lower the arm slowly. If the arm drops or is painful, it is positive and indicates tear in the rotatus cuff. Empty can. This tests for supraspinatus tendon tear. Have the patient standing. Have the patient abduct their arms to 90 degrees and with their thumbs pointing down, with their arms a little horizontally adducted. The patient then resists a downward force. Positive sign is weakness, pain, or arm dropping. Full can. This tests for supraspinatus tendon tear. Have the patient standing. The patient abducts their arms to 90 degrees and with their thumbs pointing up, with the arms a little horizontally adducted. The patient then resists a downward force. Positive sign is weakness, pain, or arm dropping. Hawkins-Kennedy impingement sign. Test for impingement of the supraspinatus tendon. This impingement test is performed by placing the shoulder at 90 degrees flexion with the elbow flexed at 90 degrees and the arm hanging down. Press back on the arm and check for any pain or reproduction of symptoms. Hornblower's sign, also known as Pate's test. This test is used to determine the strength of the teres minor. Both the patient and the therapist are standing. The therapist elevates the patient's arm to 90 degrees in the scapular plane. The therapist then flexes the elbow to 90 degrees and the patient is asked to laterally rotate the shoulder. A positive test occurs with weakness and/or pain. Lift-off test. This test assesses the function of the subscapularis muscle. Ask the patient to place the dorsum of their hand on their lower back. Apply light resistance to the hand, holding it against their back. Ask the patient to move their hand off their back by internally rotating their shoulder. An inability to do this, or loss of power, indicates damage to subscapularis. If they physically cannot put their arm behind their back, you can modify this special test by asking them to push the palm of their hand into their abdomen. Neer's impingement test. The Neer test is commonly used in orthopaedic examinations to test for subacromial impingement. From the starting position, the examiner internally rotates the patient's arm and forcefully moves the arm through the full range of forward flexion or until reports of pain. The Neer test is considered positive if patient is reported in the anterior lateral aspect of the shoulder. The painful arc or impingement test. Ask the patient to abduct their arm to its maximum point of abduction. Then ask the patient to lower their arm slowly back to the neutral position. Impingement typically causes pain between 80 to 120 degrees of abduction. Speeds test. This tests biceps tendinopathy. Have the forearm supinated and the elbow extended and resistance to forward flexion of the shoulder. Positive if tenderness in the bicipital groove, indicating bicipital tendinitis. Sulcus sign. Yergason's test. The elbows flexed to 90 degrees and the forearm pronated. Resistance to supination is applied as the patient also abducts the arm. Positive if pain in the bicipital groove and indicates bicipital tendinitis.